Hi there, it's Kathy Cates and Melissa Hines from the Institute for Pelvic Health.
And you're watching Demystifying the Pelvic Floor, weekly videos providing real and simplified pelvic floor education for real clinical situations. We've got you covered. In this video, you'll learn about pelvic floor dysfunction and why Kegels are not the answer for all pelvic floor dysfunction. Take it away, Melissa.
All right, so first we're going to go over the normal function of the pelvic floor, the motor control of the pelvic floor. So there's three main actions of the pelvic floor muscle. The first is contract, or what a lot of people think Kegels, relax, which we like to call a pelvic drop, and bulge, which is essentially bearing down. So the pelvic floor muscles are a really cool group of muscles because they have autonomic function, which is involuntary, as well as voluntary function. So we have control of if we can contract, relax, but we also don't have control of if we contract, relax. The muscles will automatically do that for us. So for instance, involuntary would be the compressor urethral muscle contracts to prevent urinary leakage as the bladder fills. We're not thinking about that. It's just doing that. The other is the voluntary is your ability to contract those muscles if you have to pee and you're not near a bathroom. So things can go a little haywire if there's issues with the pelvic floor muscles or dysfunction. So the two forms are hypertonicity, overactive pelvic floor muscles, or hypotonicity, which is underactive pelvic floor muscles. So the opposite. For hypertonicity, that overactive pelvic floor muscles, they're not able to relax, or they contract when they should be relaxing. Some symptoms or diagnoses, generally these are like pain disorders, dyspareunia, voiding problems, overactive bladder syndrome, constipation can be one. In this case, you would not want to prescribe Kegels. You'd actually want to do the opposite of that. You don't want to do any sort of up training. So you're thinking more deep breathing with pelvic floor relaxation, which we'll talk about more at some point. Signs and assessment. So Kathy will go through this for an NP perspective later on, but in general, there's an absence of voluntary pelvic floor muscle relaxation. The patient's just not able to relax those muscles at all. There's trigger points throughout, so tender to palpation when you're doing an exam. The pain can radiate or refer to other places. And then hypotonicity, which is the exact opposite. Everything is underactive and just non-supportive. You're not able to contract when necessary. So this is what a lot of people think of as like pelvic floor dysfunction, because we always think of urinary incontinence, right, Kathy?
Right.
Fecal incontinence, pelvic organ prolapse. In this case, you may prescribe Kegels, not always. Again, we'll talk about this more, because these are generally weak muscles. For underactive pelvic floor muscle assessment, there's a lack of voluntary contraction of your patient's pelvic floor. So underactive pelvic floor muscle assessment, there's a lack of voluntary or involuntary contraction of the pelvic floor muscles. When you are palpating these muscles, generally you feel your finger like really sink, and it feels super lax and pliable. There's like really no density to those muscles. And now Kathy is going to talk to you more about her NP practice and how she can quickly assess for this and how you can incorporate this into your practice.
Now, let's talk about your pelvic exam. Your external assessment. Let's make sure you're assessing for erythema, tenderness at the introitus. Take a look at that perineal body. Is it sort of shortened and bunched up, or is it elongated? Do you notice any hemorrhoids? All of these things should make your radar go off for hypertonicity, high tone pelvic floor. Conversely, if you're looking at the perineal body and you see that it's descended, then you're starting to think about hypotonicity.
Mhm.
And when you spread the labia apart, you may even notice prolapse as soon as you spread the labia apart. Then definitely be thinking of hypotonicity. Now, when we go internally for your assessment, ask your patient to contract against your finger. Can they do it? Are they bulging? Can your patient contract and release the muscles voluntarily? Do they tend to stay contracted and not really be able to let go?
Mm.
Hypertonicity. On your way to the cervix and the adnexa, notice what you feel under your fingers. Are any of those muscles tender to palpation? And if they are, think hypertonicity.
All right. And that's a wrap. Did you like this video? If so, hit like and subscribe. Please share with your colleagues, comment below to let us know your biggest challenges assessing your patient's pelvic floor dysfunction.
And subscribe to our email list at instituteforpelvichealth.com to get your free guide, 4 tips for managing your challenging pelvic exam. And you'll get access to our weekly pelvic health content.
Be sure to find us on Instagram, Facebook, and LinkedIn, where we'll post more pelvic health tips. We're super excited to announce we're developing an online pelvic health course for nurse practitioners.
Our course will break down the pelvic floor so that you can confidently care for your patients with pelvic floor dysfunction. By simplifying the pelvic floor, we'll improve patient outcomes and your experience as their provider. Thanks for watching and spreading the word. Let's revolutionize pelvic health. See you soon.